Good morning. I'm Professor Paul Froom, and I'd like to talk to you today about vitamin D. In the last few years, there's been an epidemic of testing and treatment for vitamin D deficiency. In the general population studies, if you take all those who have tested vitamin D, 70, 80, up to 80% are defined as being deficient. Are we all ill? Are we all at increased risk? And for what? Are we talking about mass hysteria or evidence-based medicine? It's certainly true that there are diseases caused by not enough vitamin D. For example, rickets because of not enough vitamin D, causes bone deformity in a child. Also, osteomalacia in adults can be caused by not enough vitamin D. Tests have gone up because of improved technology. In Canada, for example, in 2004 there were 30,000 tests of vitamin 25-hydroxyvitamin D done per year, and this increased to 2008 to 400,000 and 2009 to over 730,000. The cost for just this one test was $38 million. Now this is not the total cost, because you also have the cost of buying the vitamin D supplements, which was estimated in the United States to be around $230 million per year. When we talk about risks and benefits, we want to know if the risks of being treated by vitamin D, not being treated by vitamin D, are less or more than the benefits of being treated by vitamin D. It's also possible to do cost-benefit analysis, but in this lecture we're not going to talk about the benefits. We're going to just talk about the costs of the benefits. We're going to just talk about the benefits because it's unclear what they are. One patient got a phone call from his physician. He said, "Come in immediately. You have a low vitamin D level and you need treatment." Well, is this really an emergency? How about the worry that this causes the patient? Another worried patient went to her physician, who gave her 600 units of vitamin D because her level was less than the reference interval, 75, which is supposedly the lower limit of the reference interval, or what's considered a normal value, 75 nanomoles per liter. Well, she had 50. She took vitamin D for 600 international units daily for a month, and then the repeat test showed that it was up to 60. This was still low. Well, are 30 days enough to get another repeat level? And what should be the dose if you really want to get the levels over, you want to get your vitamin D 25-hydroxy levels over 75 nanomoles per liter? Well, here's a beach. On a beach, you get sun, and sun is known to cause the skin to produce a large amount of vitamin D. Of course, this has to be in the midday and not at sunset. Well, here I am in medical school, and I didn't get vitamin D supplements. So, could I have prevented aging or aging-related diseases by taking vitamin D daily until I'm now at 45 years later? Well, let's talk about the basics. The serum concentration of hydroxyvitamin D is the best indicator of vitamin D status. This is what has been claimed. Vitamin D comes from three sources: skin, food, and supplements. The half-life is 15 days, which means that the level in your blood is fairly stable. What that means essentially is if you don't get any vitamin D and you start out with, say, a level of 100, in 15 days it will go down to 50. Now, vitamin D can come from your diet or come from the skin. The vitamin D then goes to the liver, where it is then transferred to 25-hydroxyvitamin D, and then goes to the kidneys, where it's activated to 125-hydroxyvitamin D. The 125 is what actually the body uses, and that is the active vitamin D. But 125 is generally not considered a good indicator of vitamin D status, because even when levels of 25-hydroxy are very low, the 125 are usually normal. It also has a very short half-life, 15 hours, so it is unstable. But actually, maybe the 125 is all that really is important. But what are the accepted levels of 25-hydroxyvitamin D that are considered normal? Well, the normal reference range is usually considered 75 to 150, where over 150 may increase morbidity. 50 to 75 is considered marginal and adequate if you're a healthy individual, whereas 25 to 50 and 12 to 25 is thought to be inadequate for bone and overall health. Finally, severe deficiency is defined as under 12 nanomoles per liter, and this is associated with an increased risk for bone disease, rickets in infants and children, and osteomalacia in adults. Here is a population study with levels here are 28, 29, perhaps 30, and this probably is nanomoles per nanograms per I don't remember what exactly it is, the units, but these are not the nanomoles per units. And you can see here that in September you get a maximum value in this population. Well, this is because that over the summer, June, July, August, you get increasing, because of sun exposure, you get increasing blood levels that maximize in September. But even at maximum times, you can see here that if you use the definition of 75 nanomoles per liter, that 80% of men, the blue is men and the red is women, at least 80% of people during all times during the year are going to be deficient. Well, is this really deficiency? 45,915 samples in an outpatient population, you can see that it is distributed fairly normally. This means that your median value, where you have half over and half under, is the same as your mean value, which is 52.8. Here 52.4, 52.8 is pretty much the same. And then what it means is that you have a population mean, and then whether you have increased or lower values happens randomly. And this gives you a normal curve. A normal curve might suggest that these values are all is from a normal population. Because if you had a normal and sick population, you might expect that you'd have one curve like this, and then another curve with the peak shifted to the left. But this we don't see. So what is the lower limit of the reference interval? Is it really 75, where then we have 80% of the population with low levels? Or perhaps it's 7 to 8 nanomoles per liter. How do you determine in usually what is the reference interval in a normal population? Is you take a normal population and you say 95% are normal. The other 5% on either high or low values are abnormal. This is sort of a contradiction in terms. In any case, if you start out with 52.8 as the mean, and then you take 22.7 times 2, which is the standard deviation, minus you get the lower limit of 7.4. So perhaps that should be the lower limit of the reference interval. Well, how do you treat vitamin D? You can expect to get a 25 nanomole per liter increase for every 1,000 international units. Here you can see that the other units that I forgot earlier are nanograms per milliliter. You can get daily treatment, or because of the long half-life, you can have longer intervals. There is treatment given every 2 weeks, for example. Now here is an example of the half-life and what the importance is to know when to get the repeat test after you started treatment. Well, if you start at 10, for example, after 15 days, and if the half-life is 15 days, you get from 10 down to 5. Then from 5 to 2.5 after 2 half-lives, and so on and so on. On the other hand here, you started taking the vitamin D here, and the lady that was our patient had her levels repeated at 30 days. Well, she has not reached the optimum level, stable plateau, which happens around 75 days, 5 times the half-life. There are many different types of drugs that you can give, formulas. There is, here for example, is a liquid that's 2,500 international units per milliliter. Here you have 200 international units per drop. On the other hand, this is a chewable tablet that has 1,000 international units per pill. Usually the amount of vitamin D in tablets that have other multivitamins or calcium are much lower, usually 200 to 400 international units per pill. Now what about the dose? Did our patient get a high enough dose to get an expected level over 75 nanomoles per liter? Well, here you can see at 400 international units, the person started somewhat little less than the lower limit of the reference interval, and she went down. 1,000 units there was a slight increase. 5,000 units, you can see that it was increased up to about 130. This is still below the upper threshold thought to be safe, which of 150 nanomoles per liter. At 10,000 units per day, this was too much, and you got up to an average. You got up to levels of 200. There's another thing that you can see by these graphs, that it takes around 75 days to get up to the plateau figure for the vitamin D. Here is our patients that were given 50,000 international units of vitamin D2 every 2 weeks for 6 years, and you can see that their levels were within the reference interval. This is a chart that I got off of a lecture by Hollis. How about food? Food is generally not enough if you want a large dose of vitamin D. If you're content with 200 international units, then you can take 2 cups of milk or two cups of orange juice that are fortified with vitamin D. On the other hand, if you want a therapeutic, say over 1,000 units, then you need cod liver oil. Probably the best way to get vitamin D is from the sun. 10 minutes in the midday sun in shorts and a tank top with no sunscreen will give you enough radiation to produce around 10,000 international units of vitamin D. Therefore, Hollis, who is an expert on vitamin D from Boston, recommends that in the Boston area, he recommends 5 to 15 minutes of sunlight 2 to 3 times a week, and not on the whole body, but just on the arms. Well, how about the new recommendations? There are those who recommend are 600 international units for males, females, either pregnant females or lactating females as well, and with only lower doses in infants up to 12 months, and higher doses in those over age 70. On the other hand, a recent paper by the Ontario Health Technology Advisory Committee in 2009 and 2010 recommended only 200 international units as a daily recommended dose. Hollis, on the other hand, recommends 1,000 to 2,000 international units per day, or higher doses that are intermittent, as we saw in the figure. Vitamin D is available in two forms, D2 from yeast and D3, which comes from a chemical process. However, for all practical purposes, they are equivalent. Now, there is much literature supporting the use of vitamin D, and in fact, it's good for just about everything. Musculoskeletal pain from fibromyalgia or rheumatoid arthritis, malabsorption syndromes, cardiovascular disease, the use of corticosteroids, which might affect the bones, metabolic syndromes, type 2 diabetes, chronic kidney disease and hyperparathyroidism, depression and schizophrenia, cancer, to prevent cancer, multiple sclerosis and other autoimmune diseases, infections, autism, pregnancy complications such as preeclampsia, gestational diabetes and C-sections, and even gingivitis. There's also a good story in vitro and studies and those with surrogate endpoints. For example, vitamin D has been shown to increase cell differentiation, induce cell death of cancer cells, reduce angiogenesis, blood vessel formation around tumors, which is needed for tumor expansion in some cases. It also suppresses genes responsible for enhancing cellular proliferation and improves immune responsiveness that might protect you from getting cancer. Well, all these things are good, but they are not proof in themselves. There are also ecological studies. An ecological study is one where you check in different areas the incidence of disease. And for sun, for example, ultraviolet B exposure, the United States is a good place to do it because in the south you have more sun, in the north you have less sun. And then if you might get different cancer incidences. This was a large study done in 1993 in the population figures in 1993 to 2002. And you can see that down south you get 1,200, 1,400 UVB exposure units compared to 800 and 1,000 up north. Well, they did in fact find that up north you had more of these cancers, and down south you had more of these cancers, and in the middle you had these cancers where maybe there was a slight improvement. Pancreatic cancer in case-controlled studies has been shown to be increased risk in those with higher vitamin D levels. Well, the largest studies that have been done and the best ones have not shown and proven that vitamin D is protective against cancer. A randomized controlled trial of a large number of postmenopausal women aged 50 to 79 and followed up for 7 years found that those who got 400 international units of vitamin D plus 1,000 milligrams of calcium had pretty much the same risk of cancer than those who got a placebo. In other words, it could have been a 9% improvement or a 5% increased risk. They specifically looked at breast cancer and colon cancer and didn't find any advantages for those cancers as well. Another trial of 2,686 males and females between ages 65 to 85 in the UK gave 100,000 international units of vitamin D every 4 months versus placebo, and here also they didn't find any improvement, with a relative risk of slightly increased cancer incidence and slightly decreased total cancer mortality. Of course, the confidence intervals were wide. meaning that it could be, for example, cancer incidence might have been a 14% decrease up to a 36% increase in risk. Another study, the LAPI trial of 1,180 postmenopausal white women in Nebraska, gave 4 years of supplementation with 1,000 international units of vitamin D, either with or without calcium. Now, the study was not meant to check for cancer risks, and therefore there might be a problem and a bias with ascertainment. In any case, they did not find a difference comparing vitamin D and calcium versus calcium alone. They did not find a difference calcium versus placebo. However, using vitamin D plus calcium versus placebo, there was 60% decreased risk of cancer. Now, this was limited, as you can see, the wide reference interval, the wide 95% confidence interval, because of small numbers once you've divided these patients up, and the cancer incidence is not that high. Well, what do the experts of the National Cancer Institute or the U.S. Preventive Services Task Force, how do they summarize the literature? The NCI says that there's a potential benefit, but it is limited. In other words, even if there is a benefit, it's very small, and it's not been found consistently. There are also some cancers that may be at increased risk with higher vitamin D levels. The USPSTF also said that there is inadequate evidence to determine the effect of vitamin D supplementation with or without calcium on overall cancer incidence and mortality in adults. There is a small magnitude of risk also that can, because vitamin D supplements can cause increased risk for kidney stones. So why be skeptical? In fact, up to today, there are no food supplements that have been proven to extend life. In fact, we know the major risk factors, which are age, obesity, lack of exercise, and not eating enough fruits and vegetables. There are some studies, in fact, that have shown increased damage to health in those receiving supplements. For example, antioxidants in smokers. A study done in 1994 showed that those who received beta-carotene, who smoked, the smokers, they were both smokers, and those who received beta-carotene had an increased risk after 6 years of developing lung cancer compared to those who didn't receive it. The hypothesis was that beta-carotene is an antioxidant, and if you have less oxidants in the blood, then you'll have less lung cancer. Well, here they found the opposite effect, although significant statistically, it was a very small increase, from around 2.5% to 3%. The other reason to be skeptical is that once you find that something's good for everything and not specific, you're talking about a fad and not about real scientific evidence. The other thing is that even at very low levels of 25-hydroxyvitamin D, the 125 active vitamin doesn't seem to vary very much. So maybe analogous to what we know about what we don't know about oxidants, in Robbins in the major textbook of pathology says we don't know ideal concentrations for oxidants, and we don't know today what are the ideal levels of vitamin D. Where does this leave us? Well, you can get various experts give varying opinions. Edward D. Gorheim, Associate Professor in the Department of Family and Preventive Medicine, University of California, San Diego, says it's morally unjustifiable not to give vitamin D. Edward Giovannucci, Professor of Nutrition and Epidemiology at Harvard School of Public Health, said it less strongly, but also agrees that there is a larger concern that many people are not getting enough vitamin D rather than many getting too much. On the other hand, the Food and Nutrition Board of the National Institute of Health said, with the exception of measures related to bone health, evidence of improved health by vitamin D intake is not supported, or there is conflicting evidence. We don't know. So there is a new study coming out that has just been started that called VITAL, which is going to study 20,000 men and women across the United States, investigating whether taking daily dietary supplements of 2,000 international units of vitamin D3 or omega-3 fatty acids, 1 gram, probably with a group taking one, taking both, or taking neither as a control group, and this is supposed to give us an answer to whether vitamin D will improve our health or is deleterious to our health. So what do we do in the meantime? I think it's probably a matter of belief and personal choice. But whatever your decision, remain skeptical. We know that age is the most important risk factor, but don't forget the important things for prevention. I remember a medical school student telling me that he takes multivitamins, and most of the class did take multivitamins because they eat rather irregularly, and they think that the multivitamins, will keep them healthy. Well, let's hope that you're not going to take vitamin D and then think that we don't need to eat vegetables, fruits, and vegetables, or that we don't need to exercise, or that we can remain obese. It's better to get to a lean weight. What we can do for aging is unclear, and we have no present solutions. So that is what I have to say about vitamin D. Are there any questions?